Good evening, and welcome to Keys to Successful Intraoral Radiography. This is Gail Williamson, Professor of Dental Diagnostic Sciences in the Department of Oral Pathology, Medicine, and Radiology at Indiana University School of Dentistry in Indianapolis, Indiana. What I'm going to try to accomplish this evening with you is to go through some safety practices that we can use to minimize exposure to dental patients, and then also take a look at technique. Technique is critical to quality intraoral imaging. So we'll review the principles of paralleling and bisecting angle technique, and also review common errors that occur with any type of receptor when taking intraoral radiographs. We're going to do just a brief overview of intraoral radiography. As you all know, we couldn't really practice dentistry without radiographic imaging. They're one of the primary tools in dental diagnostics, and we need them to determine disease states, to help develop informed treatment plans, and to confirm often what we suspect clinically when we examine the patient. And many times they reveal conditions that are not apparent from the clinical examination. In order to use them successfully and get the most information out of them possible, they need to be high quality and accurate to make these types of determinations. Selection criteria has been around for a number of years. The first iteration was in the 1980s. These guidelines were developed by the American Dental Association and the Food and Drug Administration to assist dentists and determine appropriate examinations for dental patients, and also to keep exposures to patients as low as reasonably achievable. These guidelines are based on the evidence of disease patterns as published in the dental literature, and also these guidelines are based on typical findings in the patient's medical and dental history, and are based on clinical and signs and symptoms of disease that you might observe when examining a patient. Risk factors are taken into consideration, as well as the age and dentition of the patient. For instance, risk factors might include a patient that has poor oral hygiene, low fluoride exposure, maybe xerostomia, increasing their caries risk, evidence of past caries or periodontal disease, and the like. Another aspect or factor in the guidelines is whether the patient is a new patient, someone we have not seen before, or a recall patient that is regular to our practice and we know a great deal about their oral condition and regularity in coming to the practice. Although sometimes there are problems with prescribing radiographs, they're often based on the insurance payment schedule rather than selection criteria. If you look at the guidelines, the only time-based intervals are those that are assigned to bite wings, and this is based on risk factors for caries. The selection criteria guidelines, if you want to read about them and download the entire document, you can use this link, and you can also download a chart that you'll see next. So this is just a summary of the guidelines that you can see here. The full mouth is indicated for new patients on the adolescent and adult, for example, when the disease is widespread and not localized. And then you can see the interval for bite wings is more frequent if the patient is at high risk for caries, and longer intervals if they are at low risk for caries. Ways to minimize exposure. Our key objectives is to maximize the diagnostic value. So typically, once the survey is prescribed by the dentist, that survey is then delegated to staff, typically hygienists and assistants, who will be taking the radiographic images. So it is their responsibility to make sure they use high-quality techniques and keep the exposure to the patient as low as reasonably achievable. There are a variety of methods that you can employ to reduce exposure to patients. The number of radiographs taken, the receptor that you choose, the filtration of the X-ray beam, beam collimation, and patient shielding. We must remember that radiation has a cumulative effect. Recent research has documented that there's no dose of radiation that is considered safe, and that the risk is greater than what we once thought. So it is important to make sure that radiation is kept to a minimum. The prescription of radiographs should be on an individualized basis, as we just discussed, according to selection criteria, and we will be careful in our technique to avoid retakes. With receptors, we have a number of receptors at our disposal. We have film. We also have digital receptors that are becoming more and more common in general practice. F-speed receptors are not as fast as digital receptors, but they would be preferable over using D-speed film, which many practitioners still use. The digital sensors, both rigid and phosphor plate sensors, are more sensitive and require less radiation. There are two types of rigid receptors, CCDs and CMOS receptors. As you see here, and they're typically wired, but there's one manufacturer that has wireless. And there are also photostimulant phosphor plates. Rigid digital receptors are considered direct digital receptors, and this is because the radiation is directly received and the image is processed in real time by the computer. These devices come in 0, 1, and 2, but not all systems or manufacturers offer all three sizes. They do have a rigid construction, and this is because the internal components must be protected from saliva. These images are produced in real time and can be seen almost instantly on the computer monitor. Just to take a look at the internal components, inside these rigid receptors are solid-state circuitry, and in addition there is a silicone chip technology that's divided into an array of pixels. When X-rays interact with the sensor, they either interact directly or interact with a little scintillation screen that produces light. The amount of radiation or light that is received by the sensor creates a charge, and the total charge that strikes the sensor is translated into the different densities, the opaque and the radiolucent areas and all the shades in between. Plate receptors are very comparable to film in that they have an emulsion, and you can see that here on this slide. The blue area is the emulsion. These phosphor plates of receptors emulsion is europium activated barium fluorohalide, and this is what stores the image on the receptor until it is scanned by a laser scanner and the image is offloaded from the plate. These receptors are thin and flexible, and much like film, you would need a separate plate for each view that you take in the mouth. Receptors are available in a variety of sizes, and one manufacturer produces plates in every size that film is produced, but not all manufacturers have all sizes available. Rigid sensors and plates would have to be enclosed in a barrier to protect the plate from saliva. In addition, you would also want to protect the emulsion side that is going to receive the radiation, and make sure that the exposure side is towards the X-ray source during capture. Digital receptors of the plate variety have to be scanned in order to digitize and then view the image on the monitor. The image then can be adjusted or viewed in different ways by using software enhancement, just like rigid digital receptors. These plates would then need to be erased before reuse to make sure there's no remnant image on the receptor. Most systems will allow the plate to be erased once the plate is scanned. Another safety feature that's inherent in X-ray machines is filtration. Beam filtration removes the longer wavelength X-rays that don't contribute to image production, but rather would be absorbed in the soft tissue. Filtration and the amount of filtration that is required is dependent on the kilovoltage set on the machine. More filtration is required for machines at higher kilovoltage settings with higher penetrating X-rays. This feature of X-ray filtration is one aspect or factor that your X-ray machine inspector would take a look at to make sure it is optimal. Filtration is required by statute to be at the levels that you see on the screen. X-ray beam collimation is important to restrict the size of the X-ray beam so that the volume of tissues that expose is as low as possible. Legally, the diameter of the X-ray beam should be no greater than 7 centimeters in diameter or no larger than 2 3/4 inches. Round and rectangular collimators are available, and round is more common than rectangular. The National Council on Radiation Protection, as well as the International Council on Radiation Protection, are recommending rectangular collimation, and this is because it restricts the X-ray beam the most and reduces the exposure to the tissues by more than 50%. With digital receptors, they are much more sensitive than film to radiation exposure, and scatter radiation can degrade the digital image. So rectangular collimations not only would reduce exposure to the patient, but would also improve the image quality, and this is why they're being recommended. There are a variety of ways that you can collimate the beam. There are devices that you can unscrew and replace to produce a rectangular collimator. If your machine doesn't permit this and you're interested in rectangular collimation, there are also devices that can clip in or slide into a round collimator to make it rectangular. And then there are also instruments that will block the beam and that can be used during the acquisition of images, both film, plate, or digital. Radiation protection measures are recommended by the selection criteria guidelines, and and would include coverage particularly for children, women of childbearing age, and pregnant women if a radiograph is indicated for a pregnant person or individual. Best practices consider that lead aprons and thyroid collars be used on all patients. This is one primary way we can keep the dose as low as reasonably achievable for the patient. Shifting gears a little bit, well, let's talk a little bit about technique. Technique is the critical principle behind a quality image. So with paralleling technique, we want the receptor, the tooth structure, and the open end of the PID in the same plane, so that the central ray strikes the tooth and the receptor at the same time, at the same angulation. This will produce the best quality image possible. There are times that it is not possible to place the receptor parallel to the tooth structure, and this is often because the patient anatomy will not permit it, or patient cooperation is lacking. With bisecting angle, it means that the receptor is in angular position to the long axis of the tooth. In order to control the length of the tooth structure, you have to divide the plane in half to control the length. So bisecting angle is a compromise. It's greater angulation in the tooth long axis, but less angulation than the receptor. So what we're trying to do is direct the central ray at a right angle to that plane that's halfway between the two. One strategy that can be used if this is difficult or too abstract to understand, start parallel to the receptor and then reduce the angulation about 10 to 15 degrees, and that will usually help you achieve a bisecting angle. Bite wing technique is application of the paralleling technique for the crowns and to record the alveolar bone. This is best for caries detection and for assessment of the alveolar bone height. Just some tips to help you get organized. It is always a good idea to preset the exposure time before you place the receptor and have the X-ray head close at hand in close proximity to the area of interest. It is very important to make sure that you're setting the exposure time for each view you take in the mouth, particularly with digital receptors. Underexposure does not allow a complete record of the information to be transferred to the digital receptor. We all have our preference in terms of order, but I would recommend that you start in the anterior and then work posteriorly. This is a little bit easier for the patient to adjust to the placement in their mouth and become accustomed to before moving towards the posterior. This is what I find is most successful. Size 1 receptors work better in the anterior, especially if you have narrow arches or you're working on child patients or you're doing vertical bite wings in the anterior. I would also recommend using a cotton roll on the opposing side of the bite block to help stabilize the placement. This will reduce the amount of pressure needed to keep the receptor in the proper place and therefore not dig the receptor against the tooth structure. Especially with digital receptors in the rigid type, it's important to place the receptor as lingual as possible to the teeth. You'll get your best and more parallel placement this way. I always like to just set the placement and have the patient bite to hold or maintain my placement rather than having the patient bite it into place. I find that that doesn't work very well. It's also very helpful to give the instruction to have the patient breathe through their nose. When the patient breathes through their nose, it's not possible for them to gag. Gagging is momentary cessation of breathing, and This will help ensure that they don't gag during placement. Receptor instruments are very helpful. They're typically designed for the paralleling technique, but it is helpful in terms of aligning the beam, and there are bisecting angle holders available as well. There are designs for both film plates and rigid digital receptors. We recommend these because they help standardize technique, and when used properly will help you then reduce the number of retakes. Next, you'll just see some typical placements in the anterior segment of the mouth. The central ray entry should be along about the mid-cheek to the ala and tip of the nose on the maxilla, and through the center or middle of the mandible on the mandible when you're taking views in that area. Typically, it's best to have the head or occlusal plane level to the floor when you do the mandible, and the chin up when you do the mandible, and the chin down when you do the maxilla. If you have a narrow arch, it may be better to use a size 1 in the anterior. Typically, we'll do a midline view on both the maxilla and mandible, and then a canine lateral with that contact centered for those views on both the maxilla and mandible. If the arch is very narrow, I would suggest doing a separate lateral and a separate canine projection. You notice on these periapicals, you'll see overlapping in the premolar proximal area. We are not expecting to see proximal in the premolar area, but between the lateral canine contact. The premolar and molar periapicals, it's best to place the receptor as close to the midline as possible. Sometimes with the wired rigid receptors, it is difficult to get the distal of the canine on the periapical, so it is important to at least acquire that on the bite wing or the periapical so it is viewable somewhere in the mouth. Occasionally, if you're using size 1 receptors in the anterior, you can kind of take separate views and have the canine centered, and that may allow you to pick up the distal of the canine when you're doing a separate view of that tooth. For the molar views, it's very important to be as close to the midline as possible, and on the mandible as close to the tongue as you can get. This way it will help you find the depth of the mandible, and it will be more comfortable, and you're more likely to get the apices of the teeth. With bite wings, whether you do them tab or holder style, it is important to have the premolar proximals open and the molar proximals open on that view. It is necessary on most adults to take both a premolar and molar bite wing projection because the horizontal angles differ between the two areas. In this instance, it's not going to be possible to get this contact because the tooth is super erupted and malposed. Here's just a sample survey showing you a complete mouth survey using all size 2 receptors in both the anterior and posterior. The way that we evaluate our surveys, if we have every contact and apex displayed somewhere in the complete survey, then there are no retakes. If there's missing information, then we try to determine what information is missing, and we take the fewest number of images over to accomplish that task. I find with rigid receptors, sometimes it's very difficult to get the distal of the canine in both the periapical and the bite wing, but we're always striving to do that so that we have full coverage of all structures when we put the composite of our images together. Next, we'll take a quick look at common errors. We're all human. We all make mistakes. Some patients are definitely more difficult than others to take radiographic images on. If I do make a mistake, then I need to recognize what the problem is so that I can make a correction. The most common error that I see, regardless of receptor type, is placement. Not recording the correct teeth, or cutting off the crowns or the root apices. It is best to follow very classic placements for each area of the mouth. For instance, on this periapical, if the bite block was resting on the second molar and no premolar included, the operator would have picked up all 3 molars on this view. If this was meant to be a premolar periapical, they have the receptor too close to the teeth, which is pushing the receptor posterior and off the horizontal for the premolars. So moving more to the midline and moving it forward would improve the projection if it were a premolar view. On this bite wing, obviously the patient's not fully closed, and the receptor's not positioned such that equal portions of the maxilla and mandibular crowns are recorded. With vertical angulation errors, we have the 2 choices here: foreshorten images or elongation. If you're using a paralleling device, I find that elongation isn't as common as foreshortening. And this is because often the receptor is angular and not parallel to the tooth, resulting in too great of a vertical angulation. This will cut off the crowns and shorten the length of the tooth structures. So to correct this, you would want to make sure you have a parallel placement, and once it's parallel, the vertical angulation would be decreased to produce an accurate length of the tooth structure. Elongation occurs when the angulation is not parallel to both the teeth and receptor, but is less angulation than that. So make sure that the receptor is parallel and that the angulation, the vertical angulation, is properly aligned. This diagram just shows you how you could produce foreshortening and elongation with a parallel placement. So foreshortening would occur if the angulation is greater than the tooth and the plane of the receptor. And elongation would be if I lined up less than the plane of the tooth and receptor. The correct angulation would be the open end of the PID would be parallel to the tooth long axis and the receptor, and the central ray, the center of the X-ray beam, would be entering at a right angle. If you're using a bisecting angle technique, foreshortening occurs when your angulation is the plane of the receptor rather than the bisecting plane. Elongation occurs when you're in the plane of the tooth rather than the bisecting plane. So remember, in bisecting angle, the correct angulation is the compromise between the tooth plane and the receptor plane. It's much like you have a big slice of pizza here formed by the tooth and receptor, and you're going to divide that in half to share it equally between you and your friend. Horizontal overlapping. When proximals are overlapped, particularly on bite wing radiographs, they render the image useless. Proximals must be open in order to adequately evaluate the tooth for proximal caries. In both of these examples here, the bite wing and the periapical, the horizontal angulation is too posterior. The X-ray head is off towards the ear with the beam pointing anteriorly. So if the beam was moved more forward, it would open these contacts. Typically, when you have overlapping in the posterior, the structures will be widened and the contacts overlapped, and many times the image will be more opaque or too light. And that's because the beam is entering at a diagonal plane rather than a right angle. This diagram shows the different horizontals for each area and where the X-ray beam should enter. The open end of the X-ray cone or collimator should be parallel to the buccal plane of the teeth. That will allow the X-rays to enter proximally. And for the canine lateral and for the central. So when you're taking bite wings or periapical, just have the patient smile and make sure the external ring or their PID is parallel to the planes of the teeth. If you have a hard time visualizing that, you can just place your finger against the buccal surfaces and that will show you the horizontal planes of the teeth. The most common errors are to have the PID too posterior this way or aiming from the anterior towards the posterior, particularly on bite wings. I was at a dental meeting this past weekend and one of the dentist's remarks to me was, "What am I supposed to say when a staff member brings me an overlap bite wing? Don't they know it's not diagnostic and it should be retaken?" Well, if we don't know how to do the correction or how to check ourselves, we're probably going to have overlapping, and it will require a retake to produce a quality image. Cone cutting errors can occur with any receptor, regardless of type. They tend to not occur typically if you're using an instrument and you assembled it properly, because the beam guide will tell you how to center the beam. Typically, I see cone cuts with tab type bite wing techniques or periapicals where an instrument is not used or a bisecting angle approach is used. There is a tendency for cone cuts to be on the mesial or anterior aspect of the image, and this is because we're so worried about the posterior part that we can't see, we tend to move the beam to posterior. Before you take the image, if you're using a non-instrument technique with a beam guide, just take a look at where the front edge of the receptor, what tooth that matches up with, and then start there with your beam placement. And then make sure the central ray is in the center of the receptor. On this one we can see we have a vertical bite wing, and we have two problems here. Not only do we have a poor placement, but you can see a cone cut here where the mesial and kind of the inferior aspect is not covered. So the beam must be in the center of the receptor for it to be uniformly exposed. Minor cone cuts usually are not a problem in terms of a retake, but when major areas of the image are cut, they should be retaken. When images are underexposed, particularly with digital receptors, they cannot be corrected truly with the software. And the reason for this is that not enough X-rays were received by the receptor to provide all of the information that is available. Low density images can be caused by setting the time too low or trying to use the same setting, particularly for digital receptors, in all areas of the mouth. This is not advisable. Anterior teeth are thinner than posterior teeth, and a higher time indicating a higher number of X-rays are needed to produce a diagnostic image. Another consideration is the patient's size. The exposure settings on X-ray machines are generally designed for the average adult patient. If your patient is an average in size, they're larger, football player type, then the setting needs to be raised for each area that you're taking. If you have someone who is extremely thin, then the time should be set lower for each area. When images are too dark, sometimes it burns out information that we would like to see on the image. With a digital receptor, you can subtract density or darkness from each pixel and salvage the image as long as it's not completely dark and overly exposed. Now, if you have made that transition to a digital receptor, you've probably noticed that they handle a little bit differently than film. And the literature bears out that actually there are more errors with rigid digital receptors when they're first used by the clinician. The observations that are documented in the literature are that there are more horizontal placement errors, meaning that on periapicals as well as bite wings, the contacts are overlapped. Typically in the anterior, it's commonly reported that the crowns and incisal edges of the teeth are cut off and the image is foreshortened. Many individuals don't realize, or clinicians, that the surface of a rigid digital receptor has a small periphery, a couple of millimeters of dead space. So you have to take this into account when you're placing the receptor and recording the crowns of the teeth. It's also commonly reported to have foreshortening of the images, particularly in the anterior segments of the mouth, and that the sensors may be more uncomfortable for some patients. This is why it's necessary to place them more lingually so that they're not against the bone. Some ways to work around these problems, I just mentioned, think lingual, move to the midline. Make sure that you're placing the receptor parallel to the teeth. If you see that it's angled, reduce your angulation to counteract that and reduce the vertical angulation so that you don't cut off aspects of the tooth structure. If the patient is uncomfortable, there are little tissue sponges that can be adapted to the covered sensor. You can use topical anesthetic or distraction techniques, and we'll talk about that in a little bit. With phosphor plates, they are thinner and more flexible. And in fact, manufacturers have tried to stiffen them a little bit so that they don't flex or curve in the mouth, which can produce an error that's comparable or appears like elongation. The recording surface, or that blue side, the emulsion side, will fully record an image like film. So that emulsion will capture the image to the edge of the receptor. The transition from film to plates is somewhat easier and is probably the most comparable to film in the procedure and the processing phase. What must be remembered is that the emulsion must be handled very carefully. If the plate is bent, creased, or crimped, it will produce a permanent scar on the plate, and that scar or crimp or bend will appear on the scanned image. If there are a lot of scars or artifacts, it would be best to replace that plate and not reuse it. With plates, just like film and digital receptors, if they are uncomfortable, again, you can attach a cushion to the covered plate, topical, or use a distraction technique to better manage the patient. Tab bite wing techniques are very nice, and if you don't want to use an instrument, I find that they're very effective for all types of receptors, but often with rigid digital receptors, it reduces the bulk on the receptor by just using a loop or a stick-on tab. With tab techniques, there's a tendency for overlap and cone cutting. So there are some strategies that you can use to be more successful when you are using a tab approach. Remember, the angulation should be slightly positive. Positive 5 is very common. You can align the tab edges parallel to the contacts of the teeth, and that tab edge then would help you guide your beam. You can also place your fingertip in the contact plane, and that will tell you the direction the X-rays should pass through the contacts. Most PIDs have lines on the side or the top of them. You can also use that to aim through the contacts and then raise it to center the beam so that you don't get a cone cut. If you find that you need to use a bisecting angle technique and you're using a bisecting angle instrument that doesn't have a ring guide, this will give you a guide on the typical angulations that are used in each area. If you are used to paralleling technique, you may not have noticed that on the side of all X-ray machines, particularly those that are manufactured in the United States, there's a device called the angle meter. This was invented by Dr. Howard Raper, who is the person who invented the tab bite wing technique. On the maxilla, you'll be able to see that the ranges in angulation vary for each area of the mouth, but are more common range in the incisor and canine area. The angulations used in the maxilla are positive, meaning the X-ray head is above horizon with the PID or X-ray beam pointed downward. And on the mandible, the angulations are not quite as obtuse as in the maxilla, and the range is less, ranging from +5 in the molar area to slightly negative, -10 to 15 in the premolar canine and incisor area. Bisecting angle is very useful when you can't get a parallel placement or the patient has teeth that are longer than the receptor. So essentially you can foreshorten them to project them onto the receptor. If it's necessary to use an occlusal technique, this is the basis for that technique. The bisecting angle would be greater for occlusal techniques, about +60 on the maxilla and -45 degree occlusal placement with a bisecting plane of about 15 degrees negative. Bisecting angle does at least provide you with an alternative if you can't get the receptor parallel to the teeth, and there are certainly instances where I have had to use this on patients, and we'll see some examples of situations where that might be necessary. With bisecting angle technique, again, we talked about the angular formation between the tooth long axes and the receptor, and you're trying to divide that in half. The bisecting plane will control the length of the receptor. If you're too close to the long axes, it will be elongated. If you're too close to the receptor, it will be foreshortened. So remember, it's a compromise between the two. We all have patients that have difficulty with radiographic techniques. And sometimes they do gag, and sometimes they do complain that the receptor is uncomfortable. I find that if I respond to their complaint by doing something, it always makes it better. And if I can gain their cooperation, I'm most likely going to be able to get a diagnostic view in that area where I'm taking the image. Here are some examples of the tissue protectors that can be placed on the covered receptor, and there are also designs that can be used for digital receptors. These have an adhesive surface on the rear of them, and you can tag them right onto the barrier that's covering the receptor. I have tori in my mouth, and I find when these little sponges are used on the receptor, regardless whether it's film, a plate, but particularly with a rigid receptor, this makes it comfortable enough to maintain the placement. If the patient gags or is very uncomfortable, you can also use topical anesthetic. I like to use the pre-injection gel. It can be painted on the edge of the covered sensor or even on to the tissue cover or protector if you have that on there. And when that anesthetic contacts the soft tissues, it will deaden it and make it more comfortable. To control the gag reflex, many clinicians like to use salt with a little pinch of salt placed on the patient's tongue or under the tongue. And this seems to be very helpful in managing patients' gag reflexes. If that doesn't work, then you can also give them a minor physical task to do while you're placing the receptor in the troublesome area. The classic distraction technique instructs the patient to raise one leg and hold it in the air while you're placing the receptor in the mouth. I find that this is very difficult for patients to maintain, but it does work. Another alternative would be to have the patient bend the toes or point the toes towards their body. To keep your feet in this position really takes some concentration. You can also have the patient hum, and as I suggested earlier, have the patient breathe through their nose, or you can also have them watch the screen for the digital image, if you're using a rigid receptor, to pop up on the monitor. What we want to do is direct their attention away from gagging onto something else. Just refocus their attention. The anatomical variations are where I tend to use the tissue cushions or an alternative technique. Shallow palates usually will require angular placement of the receptor because it's not deep enough to allow a typical parallel placement, in which case you would need to use the bisecting angle technique, or if you're using a paralleling instrument, you want to decrease the vertical angulation. Use less angulation than the ring is indicating, and that will help you bisect the angle. The receptor must be moved away from the teeth in order to get to the deepest portion of the mouth. If the patient has tori, it is very important not to place the receptor on the torus. As I stated earlier, I have tori in my mouth. I have a shallow palatal, but I have bilateral mandibular. And it's very easy to abrade a torus, and it's extremely uncomfortable if the receptor is placed on the torus. So it must be behind the torus, or if you're working around a maxillary torus, on the opposite side of the torus. And I'll show you some examples in just a moment. Narrow arches, you may need to use an occlusal technique on the anterior, or a size 1 receptor would probably work the best to accommodate the width of the patient's arch. The arch tends to widen as you move posterior, so the more lingual you can place it and have the patient biting to the end of the bite block, the more likely you'll be able to have a successful placement in that area. With edentulous patients, you would want a cotton roll on both sides of the bite block to replace the missing teeth and to have it in opposition to make it easier for the patient to bite. If the patient is edentulous on the opposing side, where they can't maintain it, you'll probably need to use 2 cotton rolls to replace the missing teeth and stabilize the instrument. Endodontic imaging is always very challenging for clinicians to work around files as well as the rubber dam. There are special endodontic receptor instruments that will allow the patient to bite but leave the mouth open wide enough that it won't disturb the files in the teeth. So here are just some examples. Here's that shallow palate. Again, I want to reduce the vertical to accommodate a more angular position so I'm closer to the bisecting plane, and I want to be placing in the midline where the palate is the highest. This may also occur on the mandible where the floor of the mouth is shallow, and you can use a very similar approach. Make sure that the apical edge of the receptor is as close to the tongue as possible. Here is an example of a pretty large palatal torus. So if I'm taking this patient, I want to make sure that I have the length of the bite block, and I'm going to be placing my receptor here when I'm doing the patient's right, and over here if I'm doing the patient's left. If you place it onto the torus, not only is it uncomfortable, but it's not likely you'll get the apices of the teeth recorded. And here on this example, you can see some great examples of some very large bilateral mandibular tori. I've had a few patients where they come together and there's really not even a space here. So we want to place the receptor close to the tongue, and I would say have the patient lift the tongue, or preferably I just retract the tongue and place the receptor edge where the tongue attaches to the floor, and then as the patient slowly closes, the floor of the mouth will drop and will accept that placement. A size 1 receptor might work better in this instance, at least for the incisor view. And also, if you look at these tori that are displayed here on this photograph, you'll see that they're pretty thick. So if you have tori that are really large and really thick, you also need to think about increasing your exposure factors. It would be preferable if you could increase the penetrating power of the X-ray beam, which is the kilovoltage. But many intraoral machines are fixed and you can't change that. So you would probably only be able to increase the time. But that's a lot of bone to go through, and the image will be too light and the apices will not be apparent if you don't adjust the time. Here you can see on these images that the clinician actually has been quite successful, and you can still make out the outline and the periodontal ligament space on the teeth. Here with a narrow arch, as I already recommended, a size 1 sensor would work a lot better. If the arch is still too narrow, then you can use a size 2 receptor and just use an occlusal technique. So you would have the patient biting on the occlusal, and I would probably put cotton rolls underneath the receptor, especially if you're using a wired rigid receptor. And the bisecting plane would be a 60-degree vertical, entering about the tip of the nose. For the edentulous patient, again, cotton rolls would be necessary on both sides of the bite block. Otherwise, the receptor will place very angular, and you will not get an accurate view of the remaining alveolar bone. With endodontic instruments, again, these are the ones that are designed, you can slip a plate or a film in here, and the patient actually bites on adjacent teeth, allowing for the files to hang down from the tooth. The nice thing about these is they do have a beam guide, and this way there's less chances of cone cuts, which are very, very common errors when doing endodontics. If you are using a hemostat or some other, like a snap array that's designed for a digital receptor, then it's very important to be familiar with entry points on the face. And then just very briefly, that will help you align the central ray to the center of the receptor. Typically, these are the tip of the nose for the maxilla, the incisor area, the ala or corner of the nose for the canine area, down from the pupil of the eye to mid-cheek for the premolar area, and down from the outer corner of the eye to mid-cheek for the molar area. And you can drop those same lines or points down to the mid-mandible for the beam to enter on that arch. So as we're coming to a close here for the PowerPoint presentation, dental radiographs are critical and important diagnostic tools in dentistry. In order for them to be valuable, for the dentist to be able to make proper judgments about patient care, they must be diagnostic and of good quality. The radiographs represent your clinical skills, and we often share images with other practitioners, especially those that we refer to. So the images can represent the office, and the higher quality they are, the better impression they're going to make on the patient and other professionals that view the images. We are the stewards of the patient's radiation dose when they're having images taken in dentistry. So it is our responsibility and ethical obligation to the patient to keep their dose as low as reasonably achievable. This is accomplished by providing lead shields, by only taking necessary radiographs according to selection criteria guidelines, to avoid technical errors that produce retakes to keep the dose as low as possible. And this can be accomplished by being familiar with the principles of paralleling and bisecting angle technique, how to correct errors, and the use of receptor instruments to help us produce consistent results with fewer errors. So at this time we'll prepare for questions that any of you might have about the material, or if you have requests for additional information or further explanation, please let me know, and I will be happy to entertain your questions. I appreciate your attention. I hope the presentation has been useful and informative and will help you improve the quality of your diagnostic images. Thank you. I have a question here that indicate or asks, is there a grade of distortion? I'm not quite sure what you mean, so if you could follow up, I would be glad to respond to that question. The next question, is there any difference in techniques when using a long or short cone? One advantage of using a long cone is that the beam is more collimated, less scatter radiation is produced, and the image is going to be sharper. If you're changing from a short to a longer cone, the distance is greater, so the time will have to be increased because it takes a longer time for the X-rays to reach the receptor. If you need more information about that, I would be glad to provide that. If you want to provide your email, I can do a follow-up on that question. There is a question about the best phosphor plate system to be used with a particular software package. It would likely be best to consult your representative about what system works best with their software or what can be interfaced with that. That's a particular product-specific question. I would have to do a follow-up on that to give you a precise answer to that. But your representative should be able to help you with that. I want to thank all of you for listening this evening. I hope it's been very helpful. I appreciate your questions, and have a great evening. Best of success with quality imaging. Thank you.